All right, so a pleasant good afternoon. We're continuing our series of talks today on vascular anatomy and cerebrovascular diseases. We're actually wrapping up today with part two of vascular malformations. We would have gone through most of it last week already. So really today is touching on, well, just getting a little bit of meat into angio-occult vascular malformations, right? So angiographically occult vascular malformations, generally referred to cerebrovascular malformations that are what we say not demonstrable on technically satisfactory catheter cerebral angiography, right? I mean, it's been known by several different names, truthfully, and the incidence tends to be estimated as up to 10% of cerebrovascular malformations with an average presenting age of diagnosis of 28 years, right? They generally present with seizures or headaches, and there's several reasons behind them being angiographically occult or angiographically cryptic. That's another way that they say it. In terms of the reasons being is that sometimes these lesions would have hemorrhaged already and the bleeding actually obliterated the lesion. So it's hard to see. Or the clot may have temporarily compressed the lesion and then after a while the clot dissolves. But in that period when you're scanning, you actually don't see it, right? Or just sluggish flow throughout the vessels or just smaller size of the abnormal vessels in itself. And sometimes the actual scan itself, you can have it may require that you do delayed films to visualize due to late filling, right? Um, so the first one that we're gonna do, and the very big one, is cavernous malformations, right? So cavernous malformations is really described as a well-circumscribed benign, is a vascular hematoma. And what it is consists of irregular, thick and thin-walled sinusoidal vascular channels, right? And that same thick and thin you would actually appreciate as hyperdense and hypodense, black and white, located within the brain, but it lacks intervening neural parenchyma. It doesn't have that intervening parenchyma. It doesn't have the large feeding arteries nor the large draining veins. It's almost like it's just a shunt, right? They could be very small. You have them as small as 1 centimeter or up to 5 centimeters in size, and it stains positive for angiogenesis factor, right? These actually represent about 5 to 13% of your CNS vascular malformations, and they develop in just under 0.16% of the population. But it's been thought truthfully that this number is underrepresented because of the fact that a lot of cases are asymptomatic, right? So the true incidence, or I should say the true prevalence, I should say, is really not known. But the peak age of presentation tends to be 20 to 40 years of age. And in essence, what happens is that you have these caverns, in essence, in between, filling with blood in various stages and can then lead to thrombus, organization, dissolution, and you can eventually have hemorrhaging, right? Actually, in terms of location, there was a large autopsy study that they did, and they correlated it with MRI that they found between 48 to 86% was supratentorial. About 10% of that was in the basal ganglia, and then 4 to 35% in the brainstem, right? Now, the other thing that we need to appreciate with cavernous malformations is that they can occur as solitary nodules. They can, well, solitary, sorry, they can occur multiple, and you can even have them post radiotherapy. All right. And we'll delve into that a little bit later. So, one of the important strides or developments that we've gotten with cavernous malformation is that we've now recognized that there's a genetic component towards it, right? And that genetic underpinning of, so in essence, you have familial cases and you have sporadic cases, right? So that genetic underpinning of familial cavernous malformations is important, especially in angiogenesis and the permeability of the endothelium. And you would see that the three subtypes, CCM1, CCM2, CCM3, and their respective genes. In particular, CCM1 is linked, the hallmark features that they see it more commonly in Hispanics per se. But what you need to remember with the subtypes of CCM is in general, they follow an autosomal dominant pattern, all right? And it's taught that the familial cases of cavernous malformations account for 20% of all cases, right? And remember, I said these are the genes that we need to be concerned about: CRIT1, MGC, 4607, and PDCD10, right? And of course, in keeping with the fact that there's a familial component towards it. They also can be found in genetic syndromes and genetic conditions that we, such as hereditary hemorrhagic telangiectasias, right? Then outside of your familial cases, you also have your sporadic cases. So if familial is 20%, sporadic is 80%, right? And like most of your sporadic cases tend to occur solitary. Sometimes they're often associated with a developmental venous anomaly, which we would have talked about last week, right? But generally, they tend to be, the sporadic ones tend to be solitary lesions. And importantly, the sporadic lesions tend to also be acquired lesions, right? And factors that would influence the getting these lesions is not, it links back to genetic susceptibility as well as cranial radiation therapy. So they found that in some studies where they've done cranial radiation therapy, patients develop cavernous malformations in that focal area after. So in terms of the pathology, I want us to appreciate this picture in terms of 3D because literally that is how it's described and how it looks. It almost resembles like a bunch of grapes. And within each of these nodules per se, or each grape, is really empty, right? So it's just like a vacuole, right? So so the pathology itself is comprised of dilated endothelial line capillary vessels, or what we call caverns, right? And they have defective tight junctions, right? So it almost, I mean, they in terms of pathology, they do describe it as a mulberry. Some people, have facetiously dubbed it as the hemorrhoid of the brain. But what we need to recognize is that there's no identifiable arterial feeders, as we would, so it's a very low volume pathology, right? In terms of, and there's no functional brain tissue, like I would have said, within the core. Some other structural characteristics that we need to be aware of is that on light microscopy, it stains for von Willebrand's factor. They don't have a smooth muscle layer. And then, of course, as I said, because you have those defective tight junctions, you see abnormal gaping of the tight junctions between the endothelial cells. So you have it permits leaking of blood, right? So this is the on H&E staining. This is how it would look, the cavernous malformation. And in essence, what you're seeing is just very multiple thin-walled vessels, right? Without any intervening normal brain tissue. All right. So how would these patients present? And these patients tend to present with either seizures, hemorrhage, or focal neurological deficits. And seizures accounts for up to 50% of these presentation of CM patients, right? And of course, when I say CM, it's just trying to abbreviate for cavernous malformations, right? So the 5-year risk of first-time seizure was 6% among CM patients presenting with symptoms versus 4% for those with incidental CMs, right? So that's important for us to recognize. Hemorrhage accounts for 25%, and it tends to be intraparenchymal hemorrhaging. But the problem with hemorrhaging is that you can't accurately determine the risk of hemorrhage. It's been very elusive. I mean, they've tried several study designs to try to determine, well, what bleeds and how, what was the annual hemorrhage factor in essence? What can we expect in terms of CMs? But it's like I said, it's been elusive. And in order to try to make it standardized, what they've done is to create a standardized definition of hemorrhage by the Angioma Alliance, which we're going to touch on a little bit, which in itself, what that is that they've proposed a definition of hemorrhage to help us to determine what the annual bleeding risk would be. Importantly, when it comes to hemorrhaging, there was a meta-analysis that they would have done that included over 1,000 patients, where in essence, they found that taking antithrombotics was associated with a lower bleeding risk, right? Because exactly what I was saying earlier, in that it's thought that the bleeding is related to the fact that you have thrombus formation within the malformation. And then the third way that they could present would be focal neurological deficits. And of course, this is dependent. And you can have this without evidence of recent hemorrhage, right? But this is obviously the presentation, and the deficit that they present with is obviously dependent on the location of the cavernous malformation, right? They generally tend to find that the supratentorial cavernous malformations tend to present with hemorrhage, seizures, and focal neurological deficits. So I was telling you about this Angioma Alliance definition of hemorrhage, which basically what it sums up is that they're saying, listen, any acute or subacute symptoms, meaning headaches, seizures, any neurological deficits, referable to the anatomical location of the malformation, accompanied by radiological, pathological, surgical evidence of recent extra intralesional hemorrhage, right? So this does not take into account the increase in the size of it or any other, without evidence of other recent hemorrhage. So a true hemorrhagic event, in essence, is considered to occur in two cases. One where you have an extra lesional hemorrhage. So in essence, outside of the cavernous malformation, you're going to see blood or subacute blood degradation products, which you tend to see because when it breaks down, you see that hemosiderin ring, right? And then intralesional subacute blood degradation products as well. And what's important here with intralesional is that if you would have previously identified the malformation, right, accompanied by with lesion growth, mass effect, edema, and of course corresponding symptoms, or if it's just this is a newly identified CM in essence, right? So what they're saying to you is you cannot consider hemorrhage to have occurred if you only see lesional growth and you don't see any of those signal changes, such as the hemosiderin around, all right? And obviously, neurological impairment following initial hemorrhage from a cavernous malformation tends to be what they found is that it's less than with other types of vascular malformations. But what we need to recognize with patients presenting with hemorrhaging from cavernous malformations is that each hemorrhage carries about a 20% risk of morbidity and a 5% risk of mortality. So these are some little nuggets, in essence, of what we need to remember as it pertains to the risk of hemorrhage in this subset of patients. So risk of first-time hemorrhage among incidentally discovered CMs tends to be low, less than 1%. But the two biggest factors that are consistently associated with increased bleeding risk is when they initially present with hemorrhage and brainstem cavernous malformations, right? So these are consistently associated with an elevated risk. Now, outside of the if they bleed, if the patient bleeds outside of the boundaries or an extra lesional hemorrhage, it tends to increase your rehemorrhage rate. They've of course found with a younger age, the hazard ratio for rehemorrhage is increased, so you have a higher likelihood of bleeding. And in the past, they've thought that being female, having a bigger size of the CM and multiplicity was linked to increased risk of rehemorrhage, but so far recent literature has shown has been inconsistent findings as it pertains to that. And now instead they're showing that the annual risk of recurrent hemorrhages tends to decline over time, with the greatest risk being during the first 2.5 years or 2.5 years, and then it decreases, right? Also, they've seen higher annual intracranial hemorrhage rates in familial cases versus in sporadic cases. Again, pregnancy and parturition were not thought to be risk factors for hemorrhage in this population, right? And we would have gone through already the use of platelet inhibitors or anticoagulation in these patients. And they've also found that there was no significant association with any cardiovascular risk factors, such as hypertension, we know that this is linked heavily in AVMs and aneurysms, right? And of course, no relation of physical activity to hemorrhage from CMs have been identified, including aerobic exercise, non-contact sports. But to be fair, they have put a little bit of a disclaimer that they don't know about high altitude climbing and scuba diving. They really can't assess or definitively say that there's no risk of hemorrhage or no correlation between hemorrhage and these types of activities. So as we get down into cavernous malformations, one of the things that I want you to appreciate is that there's a classification scheme. And what this does, it tells us, it is really a classification that shows us a schematic diagram correlating the hemorrhage as a function of cavernous malformation, right? And it's the Zabrinsky, classification of cavernous malformations, right? So it's grades 1 to 5. And as you can see here, grade 1 is literally subacute hemorrhage with a rim, this grade that you're seeing, the rim of hemosiderin around, okay? And of course, this is what you see on your MRI images, okay? And I want you to appreciate grades 1 to 5 because then it helps us to appreciate our risk of rebleeding. So that's grade 1. Then grade 2, you see these loculated areas, particularly on T2 weighted imaging here. You can see it. You see that gliotic hemosiderin stains, right? And this with areas of calcifications. And this is what they actually call on MRI your popcorn appearance, all right? So I want you to appreciate that, okay? And then on grade 3 and 4, again, grade 3 is where it's chronic and it's resolved. And we can see that you have both hemosiderin staining inside and outside, particularly on in grade 3. In terms of chronic residual hemorrhage. And then grade 4, these lesions are so small, you really cannot see them. As you can see on your T1 and your T2 hair, you're not seeing them, but you only see grade 4 on your gradient echo in terms of your MRIs. And then grade 5 is where they obviously present, and you see the hyperdense, they present with extra lesional hemorrhaging, okay? So we've seen grade 1 to 5, and what does that mean for us? Like I said, using the standard definition of hemorrhage that we would have discussed earlier and this classification scheme, what it means for us is we can then stratify high risk, intermediate risk, and low risk. So Zabrinsky, 1, 2, and 5, right? So if you remember 1, 2, and 5, so this was 5 where you actually bled, right? And then this is 1, right? Where we saw that rim of hemosiderin, and 2, the popcorn calcifications that we see. So 1, 2, and 5 was associated with a 23.4% risk of hemorrhage, right? And these are the patients that have acute or subacute clinical symptoms. Intermediate risk, however, which is grade 3, is a 3.4%, right? So you see the significant dip in terms of the risk stratification, right? And then your lowest risk is the punctate lesions one, the ones that we could not see on T1 and T2. In essence, it carries a 1.3% risk of annual hemorrhage. So let's just, hold us in the back of our heads in terms of risk stratification. So how do we identify it then? So in these patients, CT non-contrast. So the thing with CT non-contrast in these patients is not very sensitive, nor is it very specific, right? It's just that CT scans tend to be more readily available than MRI. So the thing with using CT in these patients is that it can actually miss a lot of small lesions, even some bigger ones as well, right? And it's not very specific. Why? Because the fact that these, for instance, if you look here where you see in the arrows, this is pointing, I'm telling you, is pointing to a cavernous malformation in the brainstem, which with evidence of recent bleeding. But the truth is isolated. This can overlap with other things, just random hemorrhaging, even low-grade tumors. Isolated. But they did say that if you see isolated multifocal calcifications, it tends to help you in coming up with the diagnosis of cavernous malformations. MRI. So in this subset for CMs, you want to get an MRI because this is your diagnostic test of choice. And like I was explaining, that popcorn pattern, that's exactly what you see. You see a mixed signal core. So you see some areas of gray, a little bit of black, and some white. So that is the popcorn pattern as it's supposedly described as, right? And in essence, once you see that, it's almost pathognomonic of a cavernous malformation, right? Especially if the patient has multiple lesions or has a positive family history, then definitely it's basically almost pathognomonic. In these patients, the role of angiography, it does not demonstrate a lesion. And like I said, MRI appearance is almost pathognomonic. So angiography is not necessary in classically apparent cases, right? It's only when you have a diagnostic dilemma. So just to bring us all up to speed now, then the practice guideline is going to be in terms of imaging recommendations for cavernous malformations. There's level 1 evidence to suggest Brain MRI is for the diagnosis and follow-up of known or suspected cavernous malformations. And then MRI should include your gradients, echo, your susceptibility weighted image sequences, and anybody, and again, this is level one, anybody that has new or worsened symptoms, you need to get repeat imaging, follow-up imaging in order to guide treatment decisions. Because right now, as of right now, there's no true recommendations regarding timing of routine surveillance imaging. And then there's level three evidence, to suggest that catheter angiography is not recommended unless you're suspected an AVM with it, right? Now, importantly, I just want to stick up in here for us to recognize that first-degree relatives of patients who has more than one family member having a cavernous malformation should have MRI screening as well and appropriate genetic counseling. Remember, we talked about the three different genes that tend to be involved in this, right? So how do we treat them? So it tends, the three hallmarks or modalities that have been proposed for treatment is observation, surgical excision, and the role of stereotactic radiosurgery. Now, the truth is, even after decades of literature and work in this field, there's conflicting data regarding what is the optimal management of cavernous malformations, right? Observation tends to be the number one in terms of if the patient does not present with is not terribly symptomatic in terms of focal neurological deficits or refractory seizures, then you can aim for observation. Outside of that, you have to look into surgical excision. And truthfully, as it pertains to stereotactic radiosurgery, it's not routinely recommended as a treatment option in these cases. There was actually a lot of work done by Stanford and Harvard, and I think it was at the University of Pittsburgh, where they ran controls in terms of trying stereotactic radiosurgery, and they realized that they just were not getting the effect in terms of treatment for CMs, right? So the treatment recommendation for cavernous malformations, right? And this is particularly in patients who would have presented with hemorrhage, right? And as you can see, the level of evidence is level 2 and 3, right? So surgery is not recommended for asymptomatic ones, especially those in the deep or the eloquent areas of the brainstem, sorry. You can consider it for solitary or solitary asymptomatic CMs if it's easily accessible, it's not an eloquent brain. And the reason you're doing that is because you want to prevent future hemorrhage, right? Remember, we say they're bleeding up to 25% of cases. You want to prevent the psychological burden of, these patients, time-consuming follow-ups, career decisions, lifestyle changes, or even patients who may need anticoagulation, right? You can consider early CM resection in patients with seizures, especially like I was mentioning before, if it's medically refractory, right? And again, you can consider it if it's easily accessible. And what they found here is that the surgical morbidity and mortality is equivalent to living with CM for 1 to 2 years after first bleed. After a second symptomatic bleed in a brainstem CM, however, after they've actually said that you should consider surgery after reviewing the high risk of early post-op morbidity, mortality, and the impact on quality of life. And you can consider surgery in deep CMs if it's symptomatic or had a prior hemorrhage as well, right? There's also level 2 evidence to suggest, but it is weaker after a single disabling bleed from a brainstem CM to consider surgery. And again, like I was telling you with radiosurgery, really you only to consider radiosurgery in solitary cavernous malformations with previous symptomatic hemorrhages if it's again in an eloquent area of the brain that has an unacceptably high risk with surgery, right? And otherwise, it's not indicated in CMs that are asymptomatic or surgically accessible or part of familial CMs because there is that risk of forming additional cavernous malformations. So as it pertains to incidental lesions now, because remember all of these guidelines I would have just showed you was patients presenting with intracerebral or intraventricular hemorrhages, right? So if it's an incidental lesion, then what do we do? So they've literally thought that, listen, look, Types 3 and 4 in particular, asymptomatic, incidentally discovered. We can do serial imaging studies for about 2 to 3 years. And you do additional studies thereafter based on your clinical grounds. I mean, some experts are still recommending removal for single, easily accessible incidental CMs in non-eloquent area of the brain. And again, one of the things that I want you to remember here is because the radiographic appearance is so pathognomonic in terms of the popcorn appearance. This is not something that we're going to say biopsy or excision solely to verify the diagnosis, right? So we don't have grounds to do that, right? This is an example of the brainstem cavernous malformation that you can see pointed by the yellow arrows. So in essence, on CT, the patient had an acute bleed. And then on B that we're looking at, we can see the subtle appearance of the lesion, which almost appears identical to what we're seeing here on picture C, right? Where you see that in essence, the bleed did not present. It was a little bit superficial there, right? So surgery is almost never indicated for brainstem cavernous malformations that have not bled. Operative management, like I would have pointed out before, is really suggested only after you have a history of at least 2 prior hemorrhages and confirmed on T1 weighted MRI, right? So true surgical indications in essence now, to wrap it up, is that we're saying accessible lesions with focal deficits or symptomatic hemorrhage or seizures. In essence, seizure control is lower with longer seizure duration, of course, and less accessible lesions that repeatedly bleed with progressive neurological deterioration may be considered for excision. And this would obviously apply to places such as the brainstem, right? So in essence, if we can get to it and the person has deficits and symptomatic hemorrhages or refractory seizures, then fine, let's go after it. But if it's in a hard location, then the person has to have multiple episodes of bleeding and progressive neurological deterioration before we can consider excision, right? And of course, the risk of surgery is then going to vary based on location, right? But of course, you would appreciate and understand that brainstem CMs carry even the highest risk, meaning morbidity of almost 50%, all right? So just to touch quickly in terms of what are the goals of surgery if we do pursue surgery, now that we understand the different guidelines or recommendations put forward for surgery in this category of patients. So the goal is really to completely resect the lesion, right? And use stereotactic localization or intraoperative ultrasound is particularly helpful in this regard. You're going to choose a surgical corridor along the greatest length of the CM to minimize injury to the rest of the brain. And comparatively to your AVM surgery, a wide exposure is not necessary, right? And your initial dissection is directed at separating the lesion from the adjacent brain. Once your dissection is complete, you can get that contents of that cavernous malformation capsule piecemeal so that you minimize the parenchymal opening, okay? So these are just some of the steps in terms of the other thing is with CMs that have bled, usually encounter a cavity containing obviously not just the malformation, but also blood degradation products. And like I said, you always have to be aware of whether or not you're going to bounce up onto a developmental venous anomaly, which we would have discussed in length last class. But they did say that it does represent a venous area of the brain like we know, but they tend to regress. So even if you meet the DVA, you don't necessarily have to go after it because it would regress once you completely remove the cavernous malformation. And of course, as it pertains to deeper CMs, then we have to do surgical corridors based with reference to the brainstem and the thalamus, etc., which we will not get into for the purposes of this discussion. So in terms of prognosis and follow-up, once you completely remove them, the risk of further growth or hemorrhage is basically eliminated, right? And for CMs that are treated surgically, patients do need to be aware, however, of course, that post-operative neurologic worsening is very common, especially with your brainstem CMs. So these are the patients, like all of our patients that you're going to counsel extensively that listen, hey, if you get all of it, all of your symptoms are going to go away. But of course, there's always the risk of neurological deficits, etc. Follow-up MRI is recommended about 3 months post-op. It really never looks normal, is what the literature says, but it can determine if removal was complete, right? And just to note, sometimes, of course, as we know, the worsening can be transient and sometimes can take up to months to resolve. So that really sums up cavernous malformations. So we're just going to touch quickly on a couple other topics and then we're done. So capillary telangiectasias. Now, these tend to, in terms of cerebral ones, they tend to be clinically silent, and their discovery, largely is incidental, right? So what they are, they're small lesions, and you tend to find them in the pons, the middle cerebellar peduncles, as well as the cerebellar nuclei, right? And it composes of small dilated capillaries. They don't have any smooth muscle or elastic fibers, but it's intermixed with normal brain parenchyma. And that's one of the crucial and critical differences that you see here. But of course, you can have multiple lesions, but the intervening brain that is in between all of this tends to be very normal, right? So like I said, it tends to be clinically silent or it can be found incidentally on your imaging or at post-mortem, right? Truthfully, there has been several arguments saying that, these lesions represent the early stage in terms of the spectrum of the development of cavernous malformation. So it's almost like they're saying, look, this is not a real entity. This is something that just happens, is the early stages of a CM or some other mixed vascular malformation. But truthfully, that hasn't been proven. And what they do know, sorry, is that angiogenesis is believed to play a role in lesion evolution, right? And in essence, it dates back to faulty embryogenesis. And what is important with capillary telangiectasias is that they've been associated with syndromes and phacomatoses such as Osler-Weber-Rendu and Lewy Bosc, as well as Wyburn-Mason vascular malformation syndromes, right? So, okay, capillary telangiectasias. What are we going to do about it? MRI. Again, MRI is what? It is the most sensitive imaging modality for the identification of brain capillary lesions, right? Even though they tend to be a little bit, and you can see it here in this encircled, right? Even though they tend to be a little bit inconspicuous on your pre-contrast MRI, right? It tends to be slightly hyperintense, sorry, on your T2 weighted imaging, right? So MRI again is the gold standard as it pertains to capillary telangiectasias. Okay, so we consider it, we got the MRI, it shows us this. What are we going to do? Really and truly, they're non-operable lesions, and we tend to honestly be conservative about them, particularly because most of these lesions are asymptomatic. If they fall into conditions that are associated with a syndrome, such as ataxia telangiectasia or the hereditary hemorrhagic telangiectasia, which these all have their own scope of management, which again, we're not going to get into for the purposes of today, but in essence, you would treat them accordingly to those spectrum, those syndromes. But other than that, routine care, and you can do, like I said, additional screening if you're concerned, but these tend to be conservative management, right? Osler-Weber-Rendu syndrome, I would have mentioned it. We also know it as hereditary hemorrhagic telangiectasias or capillary telangiectasias, as we're on the subject. This one is a rare autosomal dominant genetic disorder, affects up to 1 in 5,000 persons, and most of them present with recurrent epistaxis, right? And it's associated with cerebrovascular malformations, venous angiomas, as well as aneurysms. And these are the cases that we're going to do a CT and or an MRI for these patients, right? Surgery is indicated mainly for evacuation of the hematoma, or for the diagnosis, especially when it's favorably located, right? And there's other syndromes, like I would have mentioned, that come to mind when we think about this, as I would have just mentioned. Also, Stewart-Weber syndrome is another one that you have to be aware of in terms of vascular malformations, right? And like I said, in terms of MRI, in this one, you're seeing the bilateral, it's a little hard to see, but it's right in picture 1 of bilateral hyperintensities in the substantia nigra, and then in the globus pallidus, you can see it's a little bit more clear here in terms of your T1 weighted images to show us exactly that these are your capillary telangiectasias. So that's on MRI. And then on CT, because I did say you can do CT or MRI, right? CT tends to show you a well-demarcated, homogeneous, high density. And obviously it's high density because of the fact that it's a hematoma. You can have calcification, you can see a little bit of thrombosis, and you do see some semblance of contrast enhancement around the lesion, all right? These are not the ones that you generally have, that big perilesional edema or mass effect. So to wrap up, we've gone through most of the vascular malformations last class, and now we just wrapped up in terms of what was remaining. And I figured this was a nice table to include in terms of categorizing it as arterial or mixed, which would have been what we discussed last class, or AVMs, or dural arteriovenous shunts, or carotid cavernous fistulas, and VOG malformations. And remember, these were all high flow because they had an arterial component, right? The AVMs, you can find them throughout the CNS. These were the ones that presented with hemorrhage, seizures, headaches. Your shunts were the ones that we said we could get tinnitus and hemorrhage as well. And your carotid cavernous fistula, remember we talked about type A, B, C, and D. And they tend to present with exophthalmos. They can have conjunctival congestion, and our vein of Galen malformation that we saw really in our pediatric population, where these kids were the ones that had hydrocephalus. They could have presented with newborn or pediatric CCF, right, as well as frontal bossing in essence. And then venous, we spoke about our cavernous malformation. And now these are the low flow ones, as well as our capillary telangiectasias, right? And again, we just went through this: seizures or an incidental finding for our CMs, and of course, capillary telangiectasias. We said it really depends on where it is, etc. You can get some level of cranial nerve palsies. So cranial nerve, sorry, not cranial, central nervous system vascular malformations, largely they're categorized and they're based on their various features, right? And this is what, the entire summary of it is that based on the anatomical location, clinical presentation, radiologic investigations, and the hemodynamic status of the patient. And the bottom line through all of this, is that the key pathology underlying these malformations is impairment in that integrity of the capillaries, the venous, and the arterial beds. And once you have something that impairs that integrity or loss of integrity, then you're going to have these insults to vascular development. So that at least if we don't walk away with anything, we could walk away learning this. AVMs, that was where they had that nidus, the abnormal tangles of blood vessels connecting your arteries and veins. And remember, we went through the symptoms and the treatment. We went through, you can do endovascular embolization, surgical resection, CMs, we just spoke about that it's just abnormal clusters of small dilated blood vessels, meaning that, it's really like a shunt. There's nothing, there's no normal, there's no brain parenchyma in the mix of all of this. And basically, we aim to observe unless the patient is significantly symptomatic, then we do surgical resection. Or DVAs, same thing, typically no treatment unless symptomatic. Capillary telangiectasias, usually asymptomatic, and these are the ones that we observe. And then we would have spoken again about our AV fistulas or VOG malformations and our mixed angiomas. And again, what I want us to take away from all of this is the fact that, when we understand the underlying pathophysiology and the differentiating vascular malformations, in order to truly treat these patients, is about early recognition, timely treatment, doing our regular and our appropriate MRIs, CTs, DSAs, and systematic surveillance in these patients, right? Because and then what that allows us to is the underlying theme is to stratify these patients into high risk and then creating personalized interventions for them, because we realize that a lot of these, is a lot of gray area in terms of managing the patients, right? And that brings me to the end of vascular malformations. And these